they actually would treat people by, tempting the uterus with things that they thought they would like say, like you should have sex. Like if you are unmarried, the reason you're having health issues is because you need more sex. Or literally they would hold up sweet things to like the pelvic area to say, like, tempt the uterus to come back to where it's supposed to be.
This episode was brought to you by Alloy Health and Rivian. Today, we're talking with Dr. Karen Tang, a board-certified OBGYN who specializes in minimally invasive gynecological surgery. We'll discuss how it has evolved over the years, what is it, who does it, and more importantly, if you are contemplating surgery, are you a candidate? Welcome, Dr. Tang.
Dr. Malone, I'm so excited to be here.
Your best-selling book, It's Not Hysteria, is really a great reference book because it really has all things gynecologic. So, anything that a patient wanted to know about their bodies, about procedures, about things that they may encounter. So I want to ask you a little bit about, the beginning, because as I read your book, one of the first things that really struck me is that we kind of started from the same way of sort of explaining our field. Gynecology is really a specialty that really has its roots in racism and misogyny. They kind of go hand in hand with how our field was created. And you talk about, J. Marion Sims, and I've spoken about him, the father of gynecology. And I'm embarrassed to say that as a gynecologist, I knew his name because of the procedures and the instruments that we used. But I never knew the history.
It was maybe like around like when COVID happened that I first heard about it because there were women who were protesting the statue in Central Park. There was a statue of J. Marion Sims, and that was the first time I actually had ever heard that story. For those who don't know, J. Marion Sims he was called the father of gynecology, and he was very famous for developing techniques for surgical repair of vesicovaginal fistulas, which can happen because of childbirth. And what most of us didn't know is that he actually had experimented on enslaved women. That he had practiced his techniques on unanesthetized slave women. The actual number is unknown, but there were 3 women, Betsy, Anarcha, and Lucy, who we actually know their names, but there were many more who were unnamed. And it was quite shameful. I could not believe that I did not know this story. And, like Dr. Malone was saying, we have instruments named after him. They're called Sims retractors. The speculum that we use nowadays for pap smears is actually developed by him. I couldn't believe this. I thought this was a rumor. When I was researching my book, I actually found the whole scanned copy of his journals where he literally wrote about, he bent a spoon. He literally bent like a pewter spoon so he could retract and look inside the vagina. So all of this it's just stranger than, you would think it'd be like fiction, but it's actually the harsh and terrible reality of our field. And I think the fact that it's taking us so long to acknowledge and even know that this existed, I think it is part of the reason that there's so much embedded, racism, misogyny into the history of our field that we didn't even recognize. And it sort of infiltrates the way that we see patients, the lack of research, how different women, Black women are viewed in terms of their perceptions of pain. It really is quite foundational. So.
Right. And even just the notion that it took until the 1840s before gynecology, even as a field of study, was something that anyone was ever interested in. I think that was probably his biggest contribution, was women need somebody to look at their women parts, that in and of itself was revolutionary.
That's why I felt it was important for the book to start with a history chapter. I think I made the point to my editors. I was like, I feel like I can't just launch into medical facts without giving a groundwork, because it's not just about lab values and hormone levels. It's about human beings. So it was really something that I felt very strongly about to kind of center it and give this, this context. And also, as I was writing, each of the different sections in the history chapter, I kind of draw back an association to how things happen now. So for instance, the a lot of women with endometriosis, which is a very common condition that causes chronic pelvic pain, are told still today to get pregnant to treat their endometriosis. And the reason that that rumor exists is because people may temporarily feel better in pregnancy, like because of hormone changes, but it's obviously not like a long-term fix. The crazy thing is that like women have been told some variation of that to get pregnant to fix their health problems for like all of human history. So it's like all the way back to like ancient Greek and Egyptian times and ancient Roman times. Like we were like, well, is there something wrong with your health? Just get pregnant. It means your body's starving for pregnancy, or that's going to be the answer.
Oh, please tell this story about the wandering womb.
The wandering womb. So yeah, literally,
I've never heard of it.
Isn't that funny? I love this story. So yeah, ancient Greek, Roman, Egyptian times, they literally thought your uterus moved around your body and that it was like almost like an animal, like seeking things, seeking sex, seeking pleasurable things, seeking pregnancy. And so they actually would treat people by, tempting the uterus with things that they thought they would like say, like you should have sex. Like if you are unmarried, the reason you're having health issues is because you need more sex. Or literally they would hold up sweet things to like the pelvic area to say, like, tempt the uterus to come back to where it's supposed to be. And even, like Plato, like one of these foundational, like philosophers, he's like, this founding father of philosophy. Like there's literally quotes about him saying like the wandering womb and how it affects like women. And it's just wild. It sounds so ridiculous, but like this literally was like for, hundreds of years, something that people actually thought, like these actual, health specialists thought was what was happening with the body.
Right. Because they thought that everything that women, somehow it was always just shrouded in equal parts mystery and shame.
Exactly.
They kind of went hand in hand about why we behaved. And I think that, historically people just threw their hands in the air and go, oh, women, they're so complicated. Why even bother?
So crazy. Yeah.
Come up with something crazy. And then now we have subspecialties in GYN, and some of which are really of a relatively recent vintage. And I want you to just go through it because people don't understand what the difference, like what do the different subspecialties do?
Yes. And this is so exciting for me to talk about because I don't think anybody has ever asked that in an interview. We jump right into like the specific issues and topics. And like a lot of people don't realize that there are these subspecialties for people who need more specialized care. So minimally invasive GYN surgery is for the surgical management of things like endometriosis, fibroids, cysts. And it sort of is related to pelvic pain because so many of those conditions cause pain that our specialty also trains in the diagnosis and management of complex pelvic pain. So we work very closely with pelvic floor physical therapists and the urogynecologists who specialize in the bladder and the pelvic floor and bladder function and the support of the pelvic organs. There's, cancer. So there's GYN oncologists. There are high-risk OB specialists called maternal fetal medicine. So there are all these different subspecialties that really kind of dive into more of the specialization. So I think a lot of the struggle that sometimes the average patient goes through in trying to get the care that they need is that they may only ever, depending on where they live, if you're a more remote area, only have access to just, not just, but like to a general OBGYN and not to some of these like uber subspecialists. And it's very hard. Like, it's just like primary care where primary care doctors are absolute, heroes because they're trying to handle so much. And I feel exactly the same way about rural OBGYNs because they're literally doing the jobs of like 10 different doctors. But that's very difficult. And it's hard for the doctors. It's hard for the patients sometimes if they're really kind of, have a very complicated situation medically, and it's hard to kind of get that super specialized care. So I think it's really important. It's important to talk about the system because I think a lot of people's disappointments with our field, their bad experiences sometimes is because of this difficulty getting the exact knowledge base and specialization that they need.
Right. And then the whole field of reproductive endocrinology has changed. And because again, believe it or not, when I started, IVF was relatively new and they did a lot of the endocrinology type stuff that PCOS and things like that,
Yes.
endometriosis that they don't do anymore. That's like,
Yes.
oh, nope, that goes to somebody else. That's now in your wheelhouse now.
Absolutely. So that's a big difference. So again, I started my residency in 2005. And back then, the endometriosis and fibroid specialists were the fertility doctors because, again, they were doing these surgeries and managing patients who those conditions were affecting the patient's fertility. Over time, it's changed very much because a lot of fertility doctors now, they are primarily, they're managing infertility on the level of, IUI or IVF cycles, egg freezing, et cetera. And now there's many more. So MIGS is now actually the most competitive specialty, which again, like back when I started, nobody even knew what it was. Like, what is that? And now it's become much more popular, especially topics like endometriosis have really been on the forefront of a lot of like social media discussions and things like that.
I want to get to what you do. And this minimally invasive gynecologic surgery. Do you say MIGS? What do you say?
Yeah, we abbreviate it MIGS, but so nobody knows what that is. So you end up having to say the whole long, crazy name.
Okay, so for everybody here, minimally invasive gynecologic surgery. Yeah, we're going to say MIGS from now on because that's the mouthful. Exactly. What is the difference in approach? Yeah. Minimally invasive versus traditional surgery. And I'll just tell you, traditional surgery is, you're having a hysterectomy. You go in, you have an incision. Doctors go in, they put their hands on and they remove your uterus or whatever it is that they're going in there to do, your fibroids. That's traditional, what we call laparotomies, which is an open procedure. Now tell our viewers and listeners what the difference is. What is a minimally invasive gynecologic? Because we're doing the same procedures, but what's your technique that's different? Exactly.
So the name kind of gives a little bit of the hint away. So when we think about laparotomies or what we call, like you said, open procedures, what people think of it as like the bikini cut incisions or C-section incisions. It's a big incision across like your lower abdomen for GYN surgeries to do things like hysterectomies, fibroid surgeries, cyst removal, et cetera. As you can imagine, and those of you who have been through these surgeries know, it's a lot to recover from. It's a big incision and it can be painful. It can really limit your activity, your ability to kind of like walk around and exercise and do the things you want to do in your life. So minimally invasive GYN surgery is basically using techniques that have much smaller incisions, that have less pain, risk of hernias, which are like weaknesses in the strength layers of your body, and less, blood loss, and there's less risk of scarring. It basically just gets you back to your life faster with less pain, less risk of bleeding and infections and things like that.
A lot of it is outpatient.
Yes. And I actually do all of my hysterectomies outpatient, which means that you don't have to stay in the hospital. In terms of like the experience, pretty much everybody who would have a choice would say, yes, I would rather have the version that, less painful, less of a recovery, gets me back to what I need to do. Like you were saying, there are obviously lots of situations medically where you would need to do the big incision, either because something like the uterus is just way too large. It would take forever to complete the surgery with a tiny, tiny incisions. Like you said, you have to get a huge uterus out of the body, even if you, detach everything with a tiny incision. So it wouldn't make sense to make like 4 teeny incisions and then make like an incision this big just to, cut the whole thing up.
Right. Because when you add them all up, it'd be the size of a regular laparotomy. You may have done it the other way. So tell me what types of procedures, what surgeries are appropriate for minimally invasive gynecologic surgery. So hysterectomies. What else?
Yeah, so hysterectomies, which is just to clarify, because a lot of people are confused actually about what that means. It just means taking out your uterus. A lot of people hear the word hysterectomy and they think it means taking out your ovaries and dropping your hormones or causing menopause. So just to kind of say right up front, hysterectomy is just taking out your uterus, including usually the cervix, which is the opening, the fallopian tubes. They're all attached together, and that also we mentioned a couple of times endometriosis, which is probably one of the most common causes of chronic pelvic pain, really, really painful periods, pain with sex, inflammation, bowel problems, bladder problems get worse with your periods. And endometriosis is diagnosed and removed surgically, meaning that it doesn't tend to show up on imaging studies unless it's more advanced. Which, if you imagine, like, with the incision, like a C-section incision, you have to put your whole head into the incision, like you could still barely see. So that is actually one of the few surgeries that, like, pretty much all endometriosis surgeries are done laparoscopically. It's almost impossible to really do a good job with a big incision where you can't see that closely. But surgeries for fibroids, which, can include things like hysterectomies, but also surgeries called myomectomies, which are where you cut the fibroids out of the body. And then ovarian cysts, again, most ovarian cysts can be taken out laparoscopically. Even if they're pretty big, you can still drain the fluid out and do the surgery. And then a lot of GYN cancer surgeries are done laparoscopically too. So unless there is a big tumor where you'd be afraid of, you can't cut it because it could spread the cancer. Uterine cancers, almost all of them are done laparoscopically because the cancer is contained inside the uterus. You take out the uterus, the ovaries, and do lymph node dissections all laparoscopically. So that's been a big change. Again, thinking back to when I was in residency, a lot of uterine cancer surgeries were still done with a traditional incision. Now they're pretty much all done laparoscopically. So just in those 20 years, you've seen this drastic change, which is really quite exciting. And then urogynecology, where people are having problems like your organs are prolapsing, weakness because of childbirth and pregnancy and menopause. So they can repair some of these weaknesses and lift up the vagina, the pelvic organs laparoscopically. And then that is trying to think of anything else. Oh, sterilizations. Yeah. I was there's one more. Sterilizations, we call it, getting your tubes tied. Nobody really ties the tubes
anymore.
Nobody
ties them anymore.
Yeah. Now we take the whole tube out. Yeah.
This episode of The Second Opinion with Dr. Sharon is brought to you by Alloy Health. My favorite saying is, there are no accidents in the universe. 5 years ago, my friend Michelle Obama invited me on her podcast to discuss menopause. So this is a full circle moment. She very honestly discussed her menopausal symptoms and what she chose to do about them. Michelle Obama was one of the first famous people to admit that, yes, I had debilitating hot flashes and drenching sweats, and I did something about it. What she didn't do was suffer through it. By normalizing this conversation, she took the shame and stigma out of menopause. Believe it or not, that exact conversation was the catalyst that led me to becoming the chief medical advisor at Alloy Health. The founders of Alloy Health, Ann Fullenwater and Monica Mollenauer, heard that conversation and tracked me down, and I am glad they did. After nearly 30 years of private practice, Alloy Health has allowed me to leverage my expertise, not just to my patients one-on-one, but has given me the opportunity to bring this information to women everywhere. My whole career has been about helping women feel empowered to advocate for their health. And Alloy was created with this specifically in mind. Join the 95% of women who tried Alloy and saw relief in the first 2 weeks. Head to myalloy.com and tell them all about your symptoms, and you'll get a fully customized treatment plan. And you'll get $25 off your first order today when you use code TSO25. Head to myalloy.com and enter code TSO25 to get $25 off your first order. This episode is brought to you by our friends at Rivian and their all-electric, full-size SUVs and trucks made for all of life's adventures. Rivian just announced their all-new Rivian Quad, their fastest, most capable vehicle yet. Powered by 4 motors, one for each wheel, it gives you unmatched traction, control, and performance anywhere you are. On winding roads or off-road trails, the Quad is engineered for precision driving and maximum adventure. With a native NACS port, the Quad is compatible with 50,000 DC fast chargers, so getting back on the road is hassle-free. With beautifully designed interiors, tons of storage, and incredible capability inside and out, the Quad is made for everyday comfort and rugged utility. Plus, you'll love the tech. The Rivian experience gets better over time with software updates. The premium audio experience sounds as good as the ride feels. Premium audio is part of the Sound Plus Vision package in quad and tri vehicles and can be a paid upgrade in dual models. And the Rivian Autonomy Platform Plus, a paid subscription product, offers a full suite of advanced safety and driver assistance features. There is adaptive cruise control, active lane keeping, blind spot monitoring, and forward collision warning with automatic emergency braking. Check out the all-new, all-electric quad truck or SUV and the full lineup of vehicles now at Rivian.com. You know, I've been a physician for over 30 years, and something I've seen time and time again is how illness, especially cancer, doesn't just affect your body, it can impact your entire life. So what happens when you get a cancer diagnosis and you're faced with copays, deductibles, and treatment costs? What many don't realize is that even with good health insurance, it wasn't designed to cover everything. There can be a gap. And while the gap is a problem, Aflac can help be a solution. Aflac helps with expenses health insurance doesn't cover. You might know them as the famous duck, but there's so much more than that. Since 1957, Aflac has been a pioneer in cancer insurance. They offer supplemental insurance that pays cash to help with out-of-pocket expenses. Cancer is personal. Every journey is different. Aflac's cancer coverage is designed to help through the full journey, from diagnosis to treatment to recovery and beyond. Managing an illness can be difficult, but your financial security shouldn't have to be. Visit aflac.com/cancer to learn more. After decades as a physician serving women through every stage of life, I've learned that real rest is rare, and it is essential to your health. When I travel with my girlfriends, we don't just need a place to sleep, we need a place to gather. Booking a home gives us the opportunity to be together without having to go out or get dressed up. Whether it's coffee time in the morning or a late night debrief, nothing beats the comfort of a home away from home. No matter what your needs are, Airbnb has a place for you that checks all your boxes. Plus, your own home may be a haven for someone else while you're away. My family members are not just guests. We've also been Airbnb hosts. My daughter started hosting her own home on Airbnb, and I watched how carefully and thoughtfully she tried to make every guest experience wonderful. Plus, it helped keep her out of my pocket. Hosting feels like the smart thing to do when you're away, and your own home could be worth more than you think. Find out how much at airbnb.com/host. Who is or is not a candidate? Because everything is not for everybody.
Exactly.
So what are the other reasons why someone would not be a good candidate?
Yeah, so we touched on with the cancer. So whenever you do something with small incisions, if you're taking something out, then that thing has to be able to fit out through the incisions that you're making. So that gets trickier when the target, the thing you're removing, is bigger and bigger. So at some point, you would have to cut it to be able to take it out through the incision. So for hysterectomies, we make an incision in the vagina. You can take it out through the vagina or through the incisions in your abdomen that we make. So where that gets difficult is if there's a reason that we shouldn't be cutting it. So the big one is cancer. So obviously, if you have a cancer, you don't want to kind of cut up the tumor in the abdomen because that can obviously spread the cancer. So they will actually sometimes make little kind of exceptions to this. Like if it's not that big, but they can maybe put into a bag. Like we have what's called containment bags, which are literally just as they sound, a bag that you put into the abdomen. You can put it in there and cut it inside the bag so that the pieces are captured so that they don't fall into the abdomen. So I've even had, cases where, it's precancerous condition or something where they will still do it laparoscopically. Like they'll still, cut it within a bag. But obviously that is up to the specific doctor, the oncologist, it depends on the type of tumor. So that's something that obviously there's a case by case situation. But in general, with cancers, we try and avoid cutting it so that you don't spread it. And then what I touched on with the positioning is actually important because to do it laparoscopically, again, you have to be head down. For those of you watching the video, it's a pretty steep angle, actually. So you have to be able to medically tolerate being in that head down position with the gas in your abdomen, which is pushing against your lungs and the blood flow to your heart and increasing blood flow to your brain. So for a lot of medical reasons, it's actually not safe for certain patients who have issues with their heart, their lung, their brain to be in that position for a really long time. So sometimes these surgeries can can take many, many hours. So if somebody has a medical condition where they need to get the surgery done as quick as possible, clotting disorders, they have, just other medical complexity where we don't want to keep them under anesthesia for many, many hours. So these are all things that, again, when someone is talking to a surgeon about any sort of surgery, we'll be asking about your medical history and really in our minds trying to get a sense of the safety aspect. Because of course, the main goal is a safe, healthy outcome. None of us as doctors ever take it personally when somebody gets a second opinion. Never, ever. Or at least they shouldn't. Right. There shouldn't be any egos.
Well, one of the things that comes up whenever we're talking about health disparities and who gets what and who gets offered what, it comes up all the time that Black women are less likely to be even offered minimally invasive surgery, even for the same conditions, same size uterus. It's not that, we're looking at one or the other. Why do you think that is?
I do think that some of this we talked about with these sort of ingrained biases. Again, it's not something where someone consciously is I think that I'm going to treat a Black woman differently, but just something about, and I've heard this in discussions and people talking about she has so many fibroids, or she, and I don't know if it is it's hard to have these discussions because you don't want to speak ill of your colleagues, but just that, obviously there's something.
They're not here. Go ahead.
I know I was out there. They're not in this discussion, so they can take a seat. But just obviously there's something to do with the bias because, what other reason is there? It's definitely something that we need to, as a field, be much more cognizant of and to purposely avoid, treating people differently because of non-medical factors.
It really depends on who's operating. You need to make sure that if you're going to do something that complex, you better really, really do some research on who this person is that's operating on you.
There are definitely times where we as surgeons need to know when it's helpful to do a surgery and when it is doing more harm. And like I said,
here's a general rule of thumb for you. How long, if you're doing a surgery, how long is too long?
We always have to balance the risk of the longer a surgery is, there's more risk of blood clots. There's more risk of anesthesia complications, airway swelling. So it's not a benign thing to keep someone under anesthesia for that long. So it also depends on, there's so many factors. It's hard to give an easy answer to that. But, somebody who's 20 and super healthy and really wants to preserve everything at all costs versus somebody who is, maybe 49. The likelihood of pregnancy is almost nothing, and wants a surgery where you're cutting every single fibroid out of the uterus and keeping the uterus because she wants to get pregnant. You would definitely have to have a conversation about, realistic expectations, the risk of doing an incredibly long surgery, taking out 50 fibroids when there's very little likelihood of being able to use that uterus to get pregnant. So again, we have to have these really hard conversations about ethics and goals and someone's health. So
because it's not a one and done conversation.
Absolutely.
It really isn't. And so for someone who does not get offered, what I would like to know is what would you advise someone about how would they go about finding a minimally invasive gynecologic surgeon? Because not everybody has access or not everyone is going to get referred out by their doctor. So how could they find someone like you?
Yeah. And this is actually, I have a whole chapter in the book about, what next? What happens if you are feeling like you're hitting a brick wall, you're not getting the answers that you're looking for, or you're kind of dissatisfied with the options that your doctor's giving you, or they're giving you no options. So it's a little harder to find, there's not a directory for minimally invasive, like there is for menopause. Menopause, by the way, menopause.org, there's a beautiful directory. Mary Claire Haver's website has a directory. You can find specialists relatively easily in what you're looking for. There's not a great directory for MIGs. AAGL, American Association for Gynecologic Laparoscopists, is our professional society. They do have a directory. It's not super comprehensive, but you can at least start there. So aagl.org. And then I've actually found one of the good things about social media, and obviously I have a love-hate relationship with social media, but one of the really good things is that it's allowed people to talk with others in their community or with their condition across the country. And a lot of people have crowdsourced like things like, who's a good doctor, who's a specialist in this. So for instance, for endometriosis, there are different groups that have maintained like doctor lists. There's something called like Nancy's Nook. There's, I have a lot of patients who tell me that they found me through endometriosis support group, like, on Reddit or something like that. So there's definitely, if you belong to any sort of, online discussion groups about your condition, you can say like, does anybody have any recommendations for a good specialist or surgeon in, New York City and Boston and, wherever. And, it's great because you get people's perspectives. You're like, I had a really good experience. This person really listened to me. Like my surgery was great. I felt really comfortable and supported. So it's really nice because, back before the days of social media, people were kind of just stuck with whoever there was near them. Like they didn't really have any way to figure out who was a good doctor, across the country. And obviously not everybody has the resources to travel super far, but at least you can kind of get a sense of in your region, who might be somebody who may have more expertise in what you're looking for.
Right.
So,
and worst case scenario, I mean, you can usually find someone in an academic setting. So if you're near a university hospital of some sort, there'll usually be some specialists or subspecialists in that area that you might want to take a look at.
Absolutely.
Okay. Well, you know what? We've got to have we have a little tradition here where we have a little lightning round. And
I love it. Okay. Yes.
Since October is Menopause Awareness Month, we're going to do a little perimenopause and menopause because in your practice, you don't just do minimally invasive surgery.
Mm-hmm. Oh my God. I do so much perimenopause, menopause now. I would say like a third of my practice is that. And it's actually lovely. I enjoy it so much.
Well, let me ask you this, because you trained after 2002, when the Women's Health Initiative came out and changed everything about how we talk about perimenopause and menopause. So what were you taught? Anything?
Someone had to be nearly dying of symptoms before you would get HRT. You had to have failed everything else, like, antidepressants, therapy, exercise, soy products. And then we would sort of grudgingly be like, okay, we'll try it. And then I kid you not, we would give it to them for like a couple of months and they'd be like, okay, maybe let's wean you off now. We were so scared. It was so funny now in retrospect to be like, that is ridiculous. But that's what we did for so long. And I trained at one of the Harvard hospitals. It was very, very good, education and like really evidence-based attendings. And so it wasn't like some podunk place, but this was just the scare that happened because of WHI. It really colored our perspective for so long.
So what would you say the number one misconception about perimenopause and menopause is?
Oh, that it's only the hot flashes, night sweats. I would say, and you probably see this too, I feel like some of the things that people are most bothered by are like the brain fog, like fatigue, the sleep issues. And so I think that the biggest misconception is not even just among the public, but among medical professionals. Like, what is perimenopause, menopause? Like, oh, hot flashes, night sweats. I'm like, oh, it's so much more than that.
So much more.
So much more.
Okay. So next question. Oral estrogen or transdermal?
Oh, transdermal, of course. And again, such a sea change. Back then, we were giving out so much like Prempro, and like WHI was this oral medication called Prempro, which almost nobody gives nowadays. Oral versions, which now we know because the transdermal, like the patches that you use on your skin, they don't have the clot and stroke risk. They have more even dosing. The type of estrogen, the estradiol, is like what's in your body. And it's like I said, it seems like it's just on every level it's winning. But back when we were training, they're like, how about some nice Prempro? Like, I don't think I ever prescribed a patch in residency.
At-home pap smears.
Oh, gosh.
What do you think about an at-home pap smear?
So here are my thoughts on that. One, I feel like access is obviously important. And there are definitely people who avoid coming to the gynecologist because of fear of the exam. They had a bad experience with a speculum exam, or they have a history of trauma, a history of sexual assault, where they feel like they can't tolerate an exam. That being said, this at-home pap system, I have some issues with because it's pretty large. And so for people who are worried about discomfort, there are speculums in our offices which are much smaller. So like pediatric speculums are smaller than this at-home like wand. And then there's actually also a HPV self-collection now, which is a Q-tip. It's literally like people can swab themselves. Like they can still avoid having an exam if they feel uncomfortable with another person doing it, but it's just the size of a Q-tip. So again, I feel like that particular brand and model of the at-home wand kind of testing, I feel like I get the idea of it, but I feel like the execution, I'm kind of like, well, it doesn't sort of provide anything beneficial compared to what already exists.
For traditionally, women think of going to the gynecologist to get their pap smear.
Oh, yes.
Now, that's of all the things that we're going to talk about in the course of your office visit, that may be the least important thing. However, that's the hook that makes you come. And what I'm afraid of is that if you say, oh, well, I don't have to do this and I don't have to do that and I can just do this, then you'll be missing so many things. So that's my kind of concern with the at-home pap smear test. All right. Is there anything else that you want our audience to take away from your conversation?
You don't have to suffer. That's a huge one. If you've heard that this is something that you have to deal with, this is a natural part of life, that, like everyone has bad periods, everyone has pain with sex, everyone has gone through menopause and they just dealt with it. And so you don't have to suffer just because there's sort of this cultural idea that like, well, it's like womanhood is suffering. It's not. You deserve answers. You deserve your health to be treated seriously. So, if you're getting that message from anybody, tell them they know what they're talking about, then move on. And hopefully the book, It's Not Hysteria, hopefully it helps if you have questions about any of these topics. Hopefully you'll find the answers there. So thanks so much for having me. I'm so, excited to now we're friends.
And I think we get to see each other in real life at some point in the not too distant future. So yes. Dr. Tang, thank you so much for being here. I so appreciate this conversation and I enjoyed it. It's time for the last part of the show where I give my doctor's orders and leave you with takeaways from today's conversation. Number 1, know how to describe your symptoms and know your body. Keep a symptom diary. Endometriosis and PCOS are easily overlooked or misdiagnosed. And remember, pain is not normal. When surgery is recommended, make sure to ask the question, am I a candidate for minimally invasive gynecologic surgery? Why or why not? And remember, MIGS or minimally invasive gynecologic surgery is dependent on the skill of your surgeon. This is where it is extremely important to know how often your surgeon operates and what additional training, if any, they have. Surgeons who operate infrequently traditionally have higher complication rates. So do your homework. For more information on this episode, check out our show notes. Join us each week as I break down medical topics and leave you with expert advice. Have a question you want to ask? Have feedback for the show? Submit your thoughts on my website, drsharonmalone.com/second opinion. Follow the show on YouTube or wherever you find your podcasts. If you like what you hear, leave a review. Until next week, take care.